The challenging TB case, taking this as an example of how clinicians can integrate clinical, virological, and pharmacological considerations. These are my disclosures, and we will start with the case. So after 2 years of good suppression, the patient is now failing on a regimen of tenofovir, emtricitabine, and efavirenz. Viral load has just started to come up at 1800. CD4 is still very good. And when we discussed with the patient, we revealed the adherence has been poor for quite a few weeks due to increasing fatigue, fever, worsening cough, weight loss, and we diagnosed TB. The patient is now very eager to switch therapy and be undetectable again, very concerned, but also wants to very quickly start the TB therapy. So we have a patient failing tenofovir, efavirenz, and emtricitabine with TB co-infection, and before switch, we do a resistance test. And indeed, the patient has these RT mutations, 184V, 181C, and 230L. And our folks from the TB clinic recommend giving the patient isoniazid, ethambutol, rifampicin, and pyrazinamide. And now we have to decide as the HIV docs, what's our new regimen? And of course, when giving a new regimen, we have to consider both the resistance considerations and the pharmacological considerations. And this is something which happens often when we're treating patients, especially patients who have failed. Pavel gave a very nice talk yesterday on patients who are failing their first regimen, and here the considerations both of pharmacology and resistance come into play. So usually when we look at a resistance test, what we're doing is seeing to what degree we're limited in our options. So what can we not give because of resistance? And when we're looking at our pharmacologic indications, we're looking at what alterations, what changes, either in the level of the drugs we're giving or in other drugs the patient's receiving, are going to make the levels either too high or too low, and that too is going to limit which drugs we can use. So let's just take an example so we're both on the same page. Let's look at resistance. So what's a mutation that can be telling us you can't use a specific drug? Does anyone know like the numbers of mutations and which mutation? So if the patient has K103N, which drug can I not give them? K103N, RT mutation. Efavirenz, thank you very much. And indeed, can we use efavirenz if you have K103N? No. So it's limited us saying, even if you want to give that drug, you don't have that option. And of course, we also have pharmacological considerations. If I have a patient who's getting simvastatin, one of our older lipid-lowering agents, and I want to start that patient now on darunavir or ritonavir, can I do it? Right. I can't do it, because what's going to happen to the levels of simvastatin? They're going to go way up, and we can get toxicity. So these are situations where we're being limited, and that's what usually happens in our clinical considerations when we're looking at resistance in pharmacology. Now, in rare cases, resistance in pharmacology actually can increase our options. For example, there's a resistance mutation that can make some drugs actually more active. And we often discuss it. So if you actually have the M184V, it increases the action of AZT, and there's another drug that also increases the action of tenofovir. Exactly. So actually here, it's one of those cases where we're actually getting a better option because of resistance. And although it rarely happens, we also have in pharmacology. Here it's a little bit more complicated, but I think, for example, at least something that I use in my clinic, is that if you take dolutegravir always with food, you will increase the exposure about 30%. So you don't have to take with food, because it doesn't matter if you have or not have that increase. But in some patients, if you're concerned with the levels and you want a trick that will increase your levels by about 30%, just make sure the patient takes it always with food and you have a favorable interaction. So usually resistance and pharmacology are limiting us, but in some cases, it's actually improving. Now, there's a lot of data here. There are lots of mutations. There are lots of drugs. And there's lots of drugs we give for antiretroviral therapy, and for TB, and for hypertension, and for hyperlipidemia. So there's a lot of data here, and we need all this to treat our patients. So this is very complicated. And using it in clinical practice requires us to know a lot, but even if we know a lot, it requires a lot of time. Patients like this, we have to sit and go over all the interactions and look at all the mutations, and it's very time-consuming. So here, I think we want to have technology help us, not to replace us, but to do a lot of this hard work for us so we don't have to spend so much time and learn every single mutation. We have the Stanford database that I think some of you have used and have heard of, which helps us with resistance. And we have the Liverpool Pharmacology website and app, which helps us with drug-drug interactions. And I think perhaps some of you attended a very nice workshop the day before, which dealt with using. So these two tools, these two technology aren't replacing us, but they're going to help do a lot of the hard work so we can get to treating our patient. So HIV, TB co-infection, especially in patients who have failed and have resistance, is a classic example of where we have this. I think in the talk, drug-drug interactions were specifically mentioned, and that becomes much more complicated when you have a patient who failed, and maybe if you want to use a drug like efavirenz that's recommended, you can't. So let's look at our case and see how these technologies can help us actually treating the patient. Here's our case again. Remember, the patient's failing tenofovir, tricidivir, efavirenz, viral loads coming up. We got TB diagnosed, and we have to decide now what we're going to do. Here's the list of mutations. Here's the list of drugs. And now we're sitting, and we want to decide what drugs to use. So we're going to use Stanford for the resistance, and we're going to use the Liverpool for the pharmacology. So let's start with resistance. This is the website. We don't have an app. Maybe one day we will, but you go to the website, if you click in the HIV Stanford database, you will get an interpretation system. Now, genotypic assays gives us list of mutations based on a blood test from the blood of the patient. It's looking at the virus and seeing which mutations are present, and it interprets them for us. Now, there are a lot of good interpretation systems. I'm talking about Stanford, which is the one that I use and I've been involved in for many years, but there's a lot of good other interpretation systems, and they all can be used. Stanford's available on the web, and the way we do it at Stanford is we give scores. So a score is a bad thing. So if a mutation impacts your drug, that mutation will get a score, and the higher your score, the worse the drug will work. And as you see here, we have different levels. So if it's a low score till 9, there's an impact, but it's still susceptible. If it's 10 to 14, it has potential to interact if, for example, you would add additional mutations. Low-level resistance till 29, intermediate till 59, and if you get to a score of 60 or more, that means that drug really is going to do very, very little. So we give you these interpretations, but we also have the score for you to look at. And as you have more mutations, you have a higher and higher score, and I think some of you may be familiar with this. So you go to the Stanford database, and the page opens, and there's lots of things you can do. You can have a lot of information, but we're going to look at the part of the database which interprets the resistance for you. So where do you click? You click right here. HIDV program says, you have mutations that you want us to interpret for you. You click on it, and the screen looks like this. And it's showing you all the different drugs. You see all those drugs there on that? These are all the drugs that you will get an interpretation of. Not all of them are clicked on, because we know that in most clinics, drugs like D4T or DDI aren't being used. But let's say you're a clinic that does, you can actually go in and click on these, and you'll get an interpretation for them as well. The same with the protease inhibitors. You can click on additional ones. So what do you have to do now? Very simple. Simply enter the mutations. You can either write them, or you can simply go down here and click on them. So What are the mutations we have? 184V, 181C, 230L. Let's enter them. So I'm going to click on 184V. You see it appear there, up on RT. Now let's click on the next one, 181C, and we had one more, 230L. Now we've entered them all. Now there were no protease mutations and no integrase mutations, so we're ready to go. And the next step is to press on Analyze. When you do that, the computer calculates the score for each of them and gives a result. So we have our NRTIs and our NRTIs, so let's see what's happening there. Abacavir has low-level resistance. Zidovudine is still susceptible. 3-TC and FTC, that 184 is going to kill them, so they're not going to work. And tenofovir is also susceptible. But unfortunately, all our NRTIs have now resistance. And if we go down and look at the scores, you can see this. So you see, AZT and tenofovir actually have -10. So they become very potent drugs because of that 184. But look at what happens to all our NRTIs. Everybody has a score of 60 or more, which means I don't care if it's a travirine or doravirine or any other one, you lost them. You got resistance mutations. In fact, you have 2 mutations, and that class you can no longer use. It's limiting our options. So we have 2 drugs we can use from the NRTIs, and since we have no resistance, we can use the boosted protease inhibitors or the integrase. So when we're going to make a regimen for this patient, unfortunately, we can't use the favrins, which was recommended because of resistance, but we can take either AZT or tenofovir and then give it with a boosted PI or an integrase. Okay, so now resistance has said what options we want to use. Now let's go to the pharmacology and say, okay, but with all those TB drugs, what can we actually use? So we want to give isoniazid, ethambutol, rifampicin, and pyrazinamide. And these are the options that the resistance test suggested to us. So I prefer using tenofovir to AZT because of toxicity, but you could also use ACT if you wanted. So we can give the tenofovir FCC either with Kaletra or with darunavir, or we can give it with dolutegravir. That's what the resistance limited us. Now let's look at the drug interactions and do the second part of the puzzle when making the clinical decision. We go to Liverpool. We open up the Liverpool site. It looks like this. Now in Liverpool, we don't enter mutations. What do we enter? We enter the drugs. We enter the drugs that we want to give the patient, and then we look how they will interact, and this will help us make a choice which one of them we can use. So resistance limited us to the drugs which will still work, and the pharmacology team will now tell us which of these drugs we can use and if we need to use them in a different way. So what are the drugs? So we have 4 TB drugs we're going to enter, and we're going to enter all those options from the drugs we can give the patient. We'll enter tenofovir, and we'll enter AZT, although I'm not using here, lopinavir, darunavir, ritonavir, and dolutegravir. And we'll see which of these options do or do not interact with the TB drugs we want to give. Okay, I entered here all our possible options: darunavir, ritonavir, dolutegravir, ritonavir, tenofovir, AZT, and lopinavir. And what am I going to enter in our co-medications? I'm going to enter our TB drugs. And there were 4, remember? These are the drugs that were recommended from our TB clinic. Let's punch them in. There they are. So here we have our options for our antiretroviral therapy, and here we have our TB drugs, and the computer gives us what interactions we have. And as we heard in the talk before, rifampicin is going to be a tough drug. Now, you can actually scroll down and look at every one of the interactions, or there's a really nice function. You see where it says switch to table view? If you hit that, it's going to give you a table. And the table will show you both the TB drugs and all their antiretroviral options and see where you have an interaction. So let's switch on it, and here it goes. So on one side, you got the TB drugs, and above, you have all our options that the resistance test told us you can use. And we can see on top, and for those who are at the workshop, you know that green is good, no problem. The yellow might be a small problem. Amber, you can use it, but there might be adjustments needed, and red, don't use it. So if we look at our table, ethambutol, we could use anything we want. Isoniazid, whatever you want. Pyrazinamide, no problem, but as suggested by our previous talk, rifampicin. And in fact, the boosted PIs that we'd like to use, we can't. Now, we can use dolutegravir, but it's amber. And amber means there's a potential for an interaction, and you may have to dose adjust. So the next thing we do is we click on it. We click on that amber icon, and it actually tells us what the interaction is and what we need to do. And what it's telling us is because rifampin is an inducer and increases the clearance, our levels of dolutegravir are going to go down. Now, what is this based on? This is based on studies that folks did. And some of you might be familiar with this. This was a very nice study done by Kelly Dooley and colleagues where they actually looked what happens with the levels of different drugs when you give rifampicin. So they gave dolutegravir 50 milligrams, then they gave it 50 milligrams twice a day, and then they added rifampin, and they looked how did the rifampin impact the levels of dolutegravir given once a day, how did it impact given twice a day, and how does that compare with the once a day dosing. And here are their nice results. I don't know if folks are familiar with this. This is a very nice study. So here at the bottom, that is the regular level of once a day. Now up here is if you give it twice a day, you get really nice high levels. But what happens if you add now rifampin? You get here. So by giving twice a day, you're able to compensate for the rifampin. You see it? Now, in my view, there's one other thing that happens here. Look at the slope of the dolutegravir. Instead of it being a nice long slope, it actually has a much shorter half-life. So as a clinician, I say, yes, true, you got the same levels, but adherence becomes very important here. Because dolutegravir is usually a drug that we know that if you're like 12 hours late, nothing happens. But now, because rifampin is giving it a short half-life, we need to do two things. One, we need to double the dose, but two, we have to tell the patient, listen, don't mess around with your doses. This drug has become a short half-life drug. You gotta take it twice a day, and you gotta take it meticulously. No missed doses, because now the rifampin is clearing it much more quickly. But you can compensate. And we go back to the database, and that's what it's going to tell us to do based on this study. Here, a dose adjustment of dolutegravir to 50 milligram twice daily is recommended when co-administered with rifampicin in the absence of intravenously class. So that's what we have to do. So we have our mutations, and we have resistance limiting us. And we have the drugs we want to use, and we have the consideration of the pharmacology. And now, based on all this, we can come up with drugs which will be effective despite the resistance and despite the drug-drug interactions. And what's our regimen? Tenofovir FTC with dolutegravir twice a day, and I would add with good adherence. So far, we've been able, together with the technology, to come up with a solution despite all the complexities of a co-infected patient. Now, there's some flexibility in this. If you live in a rich area where you have rifabutin, as we heard in the talk, it actually has less of an interaction. How do we know? You look at the chart, and look what happened to dolutegravir. With rifampicin, it was amber, and now with rifabutin, it's green. You can give it the regular dose. And that comes again from that study where they looked not only at rifampicin, but also at rifabutin. And here they took dolutegravir given once a day and added rifabutin and looked at the levels. And what you can see here is they're very close. it was a little bit less, but actually only 30% less. And we know for dolutegravir, if you still have 70% of the levels, you're okay. So the folks at the Pharmacology database said 30% is fine. You don't have to change the dose, and we'll make it green. So if you have rifampicin, you got to give it twice a day. If you have rifabutin, you can give it once a day. And this is how we're getting clinical guidance from these two systems in managing the patient. So in summary, complicated patients, such as those with HIV-TB co-infection, often require both resistance and pharmacological considerations. Website and app technologies can assist us in the decision-making process, but they never replace clinical judgment. They're helping us, they're augmenting us, they're saving time, they're saving some of the tedious work, but it's still our decision. And the final decision needs to be given in the context of the patient. And this is tough, because even when it's telling us dolutegravir, if we have a patient that had toxicity, and that's why we're not giving them dolutegravir, then it's not a good solution. And if we're in a place where we have rifabutin, then maybe we can do rifabutin and not rifampicin. So these are tools which help our clinical judgment. They never replace it. What I do personally is I do all this before the patient even comes in. And when the patient has come in, I'm armed now with this knowledge. It allows me to sit in front of the patient without my face inside the computer. I did all the work before, I did it, and now I can sit and discuss with the patient what the options are, why the options are, in a much better way. And by the way, the output from the Pharmacology website you can download as a PDF, and you can put that PDF either electronically into the patient's chart, or if you have a paper chart, you can print it out. And other folks who will treat the patient can actually see the considerations and what the drug-drug interactions were and why you made your decisions. And I'd like to acknowledge David Beck and Sei Koo, both from Liverpool, who have a fantastic group and have been working for years on the Liverpool database. Some of us helped them with some of the clinical considerations, and it's wonderful. And if anybody wants to do clinical pharmacology, Liverpool is a great place to learn it. And my boss at Stanford, Robert Schaefer, who is the one who started the Stanford database, and all of us are just helping him. He is really the genius of this and someone who's invested a lot of time and effort. So I'll stop here and thank you very much.
So, thank you, Jonathan.